Good afternoon, everyone, and welcome to our CARIN 2026 webinar. My name is Annette Hand, and I'm the Deputy Chair of the Communications Strand for CARIN, and I'll be chairing the webinar today. Before we begin, I would like to reintroduce CARIN. For those of you who don't know, CARIN stands for the Clinical Academic Roles Implementation Network, and it's supported by the Council of Deans and is free to join. We've got a really busy agenda this afternoon, so let's just go on to a quick few housekeeping rules so we can have our kind of slides come up, Emma, please, that'd be great. Brilliant. Thanks. Okay then, so CARIN is currently chaired by Professor Jane Coate, and it was established to advise, support and share innovation and best practice of activity that promotes and engages and evaluates the development of and implementation of joint clinical academic roles for healthcare professionals. And we've got a really packed agenda today. So just some housekeeping. The webinar will be recorded and it will be made available online. Please can you keep your microphones on mute during the presentations. Please keep cameras off if you don't wish to be seen. And please, within the function, you've got a question and answer button at the bottom. Please put any questions you've got for any of the panel members and we'll come to those at the end. So that'd be great. And our busy agenda. So we'll start off with Jane, so she's going to talk about the NMAP implementation group, and that's following the OSCHR reports. So we're all really excited to hear what's happening regarding that, Jane, and where we are with that. We're then going to pass over to, I think it's Geeta, who will look at EDI from our EDI group. We'll then be going over to Michelle and Fiona, talk about a clinical academic career framework and the work they've been involved with. And then we'll be rounding up with Mary, who will go through our metrics group and metrics and impacts group. So that's it. So let's hand over to Jane, but please put questions in the chat function.
Thank you, and I think Emma, who amazingly supports us for CARIN, is going to put up my slide presentation. Is it going to go up, Emma? So it's that long wait, isn't it? Okay, brilliant. I can see the first slide, so I'm hoping everybody else can as well. So good afternoon, everyone. Thank you so much for joining us today. As Annette has introduced me, I am the chair of CARIN, and I'm going to tell you a bit more about it in a minute. But I'm also a professor of nursing at the University of Nottingham, and I'm in a very well, it's a very wonderful position in that since last year I've been the National Strategic Lead in an honorary position for clinical academics at the Council of Deans of Health. And when we first set up that post, actually it was for nurses, midwives and allied health professionals, but we have dropped that NMAP a bit, not because we're devaluing that in any way, but we're saying much more broader in terms of healthcare professionals. And I will come on to that in my presentation. So this afternoon is really about where we are in terms of the update of our work and the implications of that for all of you listening today in terms of clinical academic roles, but also clinical research roles and all of those things. So there's lots of messages in there. Next slide. Thanks, Emma. So I like to think that we have made national progress in terms of clinical academic roles for nurses, midwives and allied health professionals. When we started this journey, and for me that started probably about 20 years ago actually, when I used to work in Birmingham, and it was very much kind of on your own, and that's why those stones are there representing that. You were kind of trying to join different groups. You were on your own. It wasn't coordinated across the UK. And you talk to people about having a clinical research or clinical academic role, and there really wasn't a place. But hopefully, with all the changes in particularly in the last 5 years, rapid changes have occurred, and opportunities, some of which I'm going to share today. We're hoping that landscape has changed. So if we go to the next slide, Emma. Thanks. These are just some of the documents. And in the top left, you can see the sort of document around clinical academic research. Now that was in 2012, so that's some years ago. Right across to the right-hand side of your screen, you can see the sort of updated documents as they come out, including the NHS plan there. In the top right, there's something called Catch, and that is a website supported by NIHR where all the resources are for clinical academics and clinical research. And I would highly recommend you look at that. I think to start with, when it first was set up, it was set up for the medical consultants, but it's just had an absolute facelift. And it's very much more inclusive in terms of its language and its resources and the case studies and everything in there. And in a couple of slides to come, I've actually got the link for you, so you don't have to worry, and you will get all of these slides. So you'll get all these resources from attending today. So that was our kind of backdrop. But you could argue, how far have we come? Next slide. So in terms of nurses, midwives, and allied health professionals, we used to meet in a group actually in the Association of UK University Hospitals. And then about 6-7 years ago, some of you who will be online and some of people speaking today will remember we were adopted, if you like, and then supported by the Council of Deans of Health. And that's when I think we transformed as this network that Annette's already said into CARIN. Now, the Council of Deans of Health, I put this slide in case people don't know, represents the UK strategic academic leaders in healthcare, education and research. And its members are those universities and further education facilities right across the UK, all working together. And actually, that's over 100. So it is a really important place, I think, for CARIN to be situated and supported by. And that is from Emma Schoenbell, who is here online today, supporting us. They are committed to all those strategic priorities. I sometimes say it's apolitical, but has huge political levy, and I hope I'm allowed to say that. So it's been amazing, and its key goals are to support member organisations, empowering them as system leaders, and build a connected community. And in fact, they have a new strategy, and again, the link is there for you in terms of the Council of Deans of Health. And we are very much part of their work. We are very much supported by them in terms of where we are going with nurses, midwives and allied health research, but also healthcare professional research in that wider framework and a much more inclusive agenda, which we would all agree with. Next slide. So Annette's already said the Clinical Academic Roles Implementation Network full title, and we all quickly just use CARIN. And I've already said it's support from the Council of Deans of Health. So what is CARIN? What has CARIN done, and has it made any difference? Well, we like to think so. And some of the work you'll hear today from the deputy chairs, I believe, emphasise that. Now, it is multi-professional, and it has lots of organisations who are partners. So that's higher education institutions, the NHS, and health and care organisations. We started small with about 20 organisations, and now we're at about 150 members. Less organisations, but over 150 members. And if you aren't a member, do contact Emma after today. Her email will be at the end. And you can see if your organisation is already represented or not. And we can go, you can go from there with the membership. The membership's free, actually. There are no snags in that. And we meet 3 times a year. And then we have this open webinar once a year, where we celebrate the work. And we do collaborate with key stakeholders. And I like to think as we've developed, we've really influenced policy and worked towards all sorts of different things in terms of clinical academic research and their roles. So a couple of the key work streams that you are going to hear some of the work today. We have key work streams around communications, And we have key work streams around equality, diversity, and inclusivity. Now, those overarch and underpin everything we do in the work packages. The work packages are metrics and impact, and we have a biannual survey, and we're going to hear about that today. Career frameworks, and you're going to hear a bit more of that today. Influencing policy, and you are going to hear from me in a minute about how we've done that. And then the devolved country work, because very much so, CARIN is for country. And so we want to work inclusively across Scotland, Wales, and Northern Ireland. Next slide. Thanks, Emma. So moving forward, what have we done in CARIN? I think as well as the separate work, which you will hear about today, for me, actually, it's that collective voice. It's from moving from those stones that I showed you on the first slide to a much more joined up approach. And that in itself, I personally think is very powerful and united. And that has made a huge difference. Next slide. But two of the things that we've really worked hard on in terms of influencing policy, I'm now going to share with you. One of them is called the Follett Principles document. Now, some of you may have heard of it, some you may not. But the Follett Principles is guidance for the joint working between higher education institutions and the NHS healthcare organisations for clinical academics. It was developed many years ago, and that was for medical consultants, but desperately needed an update. And so I'm pleased to say that in 2024, it's there, 2nd of December, we had an updated document, and I represented CARIN and was on that group. It was chaired by Professor Anne-Marie Keenan and supported by a number of stakeholders, including National NHS England and the University Colleges Employment Agency. Now, what did we do? Well, we had lots of meetings about the state of play of joint contracting and arrangements about supporting job descriptions and supporting roles. But actually, we updated the language, and that in itself is a major achievement. So we advocated for this for health and care professionals across the board. So that is the medics, but that's everyone else and everyone that this applies to, and probably most of you online. And we advocated for joint recruitment and appointment, jointly agreed induction, joint job planning, joint appraisal, and agreed processes for management of performance and conduct. And if you haven't seen it or you haven't got a link to it, I've included the link for you there because it's highly recommended, not just for you, but we're only sharing it in your organisations, but also whatever capacity you're having discussions in, whether that's as the employer or the employee. This is the document that you absolutely need in front of you and we recommend you follow in terms of fairness. So it doesn't feel like two bits of work or two bits of contracts that you're trying to do. If you just click again, Emma. Thank you. And so what we're now looking at within CARIN, and it links to some of the slides I'm coming on to, is this really happening in terms of employment? And we're trying to do pieces of work where we get case studies where it has shown that Follett is working. So if you have anything that you want to share with us, anything you think, well, actually, I had a good experience around induction or appraisal, please contact Emma after today, because we absolutely want to celebrate that so that, the good practice people can follow. Next slide, thanks. So the second thing that CARIN has been influential in is what we call the OSCHR reports. There are actually two of them. They were commissioned by the Office for the Strategic Coordination of Health Research, known as OSCHR for short, via UK Research and Innovation funding. And the first one is called the Reversing the Decline report. Now, that report came out in January 2025. and it was largely sort of said to be the medical report. And actually, it is about the medics, but since it's been published, very much so, the messages have been healthcare professionals. And I'll come on to how we're working with that report and how the implementation of that report is going forward. Now, following on, and CARIN was very much part of driving this, and members of CARIN were actually on the group supporting that, was the NMAP report, the Nurses, Midwives and Allied Health Professionals report. And it was just NMAPs, because other professional groups like dentistry, they're going to have their own in a time frame. So we've currently got 2 reports that came out called the OSCHR reports. And that was all really about the workforce of clinical research, clinical academics, and the number of professionals in those groups. Now, in the NMAP report, which we're really focusing on here today because this is about CARIN's work, we made this ambitious statement about that we would increase the number of clinical academic NMAPs over the next 5 years by 50%. Now, as soon as we wrote that, and we knew when we wrote it, actually, we knew we didn't know the numbers, the baseline. So it was a bit ambitious, but we thought we must write something about this workforce and then go forward with an increase in that workforce. We needed to do that to say we need these supportive research cultures where we work. Next slide. So the 5 key action areas of the CARIN report are around developing and embedding clear research routes and careers for NMAPs. The second one was around the culture and then the environment that makes it sustainable for clinical academic careers. The third was about equitable pay and conditions across and within the higher education institutions and the NHS. And the fourth was about robust context-specific data. So on the numbers and the distribution of clinical academics, going back to that 50% that I've said. The fifth one was monitoring progress, and we're accountable to OSCHR, and so that's what we're doing. Next slide. So what have we done? Well, it got launched in July, and then there was obviously a summer, but we had our first meeting in September 2025. And what we formed with the Council of Deans support is what's known as the NMAP implementation group. But many things we're discussing in that report have resonance, absolute resonance for all healthcare professionals. Similarly, the medical report, let's just call it that for now, it's also doing the same thing. There are things in their report very much have resonance for healthcare professionals. So we are working in that much broader framework than appears in the actual reports. I chair the NMAP implementation group as part of my strategic role in the Council of Deans of Health. Again, coordinated and supported by Emma. And so it's kept us very busy, and I'm sure Emma will agree to that the work has been, since September, phenomenal what has been happening. It's very much a 4-nation and cross-profession senior and stakeholder representation on the group. So it's a small group of about 20, 25, sort of, at a meeting. And we are working to get that sign off. It's for country, it's at senior level, and we are driving at pace to get the sign off and the sign up for each of the countries, and as a whole, driving that report forward. I think I said at the beginning that I've been committed to clinical academic research and a role myself for at least 20 years. And in the last 6 months, I've seen so much movement through this group that it's phenomenal. It feels like a real shift in the sand, and I'll come on to why. And then we're developing wider stakeholder groups, because the NMAPs are a very large group. We all know that, and healthcare professionals even larger. So we are liaising with wider stakeholder groups. So we will be liaising with the colleges, etc., to actually bring in that all much more sort of wider views across the UK. So that's where we're at with that. Next slide. We've also developed a map love a diagram. I don't know about other people, but we designed the work. Actually, there's a similar diagram for the medics. They have different colors, but it's the similar. And this maps out, and you will all get this, what we've been doing. We put the work into 4 packages of work, one around improving metrics, one around improving partnerships, one around influencing funding, and one around improving pathways and environment. Those are 4 clear packages of work from a very, complex document. And I'm going to split them apart now to share with you what we've been doing. Next slide. So immediately in October 2025, straight after that meeting in September, we have set up a number of meetings. The first thing we absolutely must do, and I'm sure it's going to relate to when Mary talks later on about the CARIN survey, we must find the numbers and track NMAPs and where they work and who they are. And a place that we knew we could start, or we thought we could start, is known as the Higher Education Statistics Agency, HESA. And HESA collects the data for an exercise that the universities do, known as REF, the Research Excellence Framework. And we believed they collect this data on staff so that they can submit them as part of that submission for the REF that universities do. We got hold of the database, and with Professor Mary Wells, who's speaking later, we did a data interrogation. Actually, I've gone back over it twice, and it's very variable where clinical academics are actually numbered and cited and actually put into their forms that then go to HESA. That was quite shocking to me. It was a bit like being Dorothy in the Wizard of Oz, and you go down a long yellow road and it's a man behind a screen. Because I thought somewhere, as a clinical academic or clinical researcher, I thought somewhere I would be counted, and we weren't, not consistently across the UK. And there's all sorts of reasons for that, and we're trying to unravel it. At the same time, we got a number of case studies from a number of universities to find out what they were thinking and why they were not putting clinical researchers down that they had on their contracted, their sort of university staff, why they weren't submitting them to this HESA data set, which they were meant to do. And there's a number of reasons also for that, and we've collected a few case studies. So we are still in the absolute, middle of this piece of work, massive. But at the same time, luck was on our side because the HESA data set was open for consultation. It only opens every 2 years, and we've been able to suggest things to improve NMAPs being collected, and indeed all healthcare professionals. So that is a major piece of work since October that we must crack, because then we know who we are, who you are, and we know how many numbers there are. Thank you. Next slide. Also commenced in October is something called the National Cross-Funder Meeting. Now that is funded and supported from the medical group. So it's the Academy of Medical Sciences who host that. And we've been invited to the table from the NMAP implementation group. And that has been phenomenal. And again, that was really interesting. In my naivety of the world, I didn't realize the cross-funders didn't already meet. So this is all your big funders: National Institute of Health Research, Wellcome, the Cancer Research, the Medical Research Council. But in actual fact, they did not meet, although they met sporadically. They didn't ever meet regularly. And because of that medical report, OSCHR, and the NMAP OSCHR report work, we have established this cross-funder group, and we have established language which is much more inclusive. So you will start to see inclusive adverts for calls for grants, inclusive opportunities within those grants. And we've compiled a wish list, which we keep bringing to the table at every meeting, so that things improve for all healthcare professionals when it comes to, being awarded this money. And we're linking with NMAP clinical academics to do that. Next slide. This is going to commence in March, so not too much to say about this yet, but this is about developing much more stronger partnerships so that, you know, we're seen and counted. We're getting the counting improved, but we also want to be seen more and doing some national partnership work. And maybe creating some kind of resource about who to go to when you need a supervisor, those kind of things. That's on the ground stuff as well as, you know, very strategic stuff. And we need it because we need to all work together. Next slide. The thing that we're currently on, and we've commenced it, actually, we already commenced it in January, so we're ahead of time here, is a visible research career pathway. Actually, we're ahead of time because the OSCHR medical report, the first one, started to do this work very early on. And one of the things they have developed, and we have worked with them on, is a national clinical research pathway. So if you can go to the next slide, Emma. If you haven't seen it, it looks like that. We have asked a number of the NMAP stakeholders, and we're still in this process because this is the sort of first real month of doing this, what people think of this pathway. But this is on the Catch website. And if you haven't seen it, please use it. For the first time, it uses a much more inclusive language of flexibility, of training, of pre-doctoral or doctoral or wherever you are in your career. We've put some really intense footnotes for nurses, midwives and other health professionals, and other healthcare professionals I think will follow. But we are all at the moment signing up to that, you know, one for all careers map. And we will see that more and more. And if you haven't seen that up to today, please do get that resource and, you know, keep it close because that will be our new careers map. And we've called it Clinical Research Careers Map, taking all the sort of different terminologies out. We're actually saying that. And we're saying 4 countries and all healthcare professionals. Next slide. So this is all the transformation in reality. Things that really have come home to me in this work. And Annette said, you know, I was doing an update and I am, is that this funder arrangements and getting around the table with the cross funders has been completely a line in the sand. It has really started to help. So when you see calls for grants and you think, oh, that's probably for medics, look at the wording because they are all going to change bit by bit. Everyone is signed up to that. And that is phenomenal. One of the things that came out of some of the employment issues work we've done in CARIN, but also in this implementation group, is sign off. Wherever you are in your career, if you're talking to your immediate manager or your senior manager or your research manager or your chief nurse, get sign off on it. Because that is crucial in employment and working on those full principles that I said about, you know, having a fair contract and being paid in that way. There is a lot of work also going on from both those OSCHR reports, not necessarily in the portfolios, but overall on employment rights. And I'm delighted to say that that's been taken forward by a number of agencies in terms of thinking about fairness across agenda for change and or higher education institution assessments. And that's good news as far as I'm concerned. Next slide. And then one of the things I've realised and we're working on that data set and looking at it with Mary, we were quite shocked about the limited metrics at a local and national level about who we are, how many numbers we are. And while ever that is the case, you know, it's really hard to report. So try and make sure locally or whatever you're doing, you get those metrics. You put yourself wherever you are in any organisation, you say, am I being counted here? Because that will really help. Because we're all part of this implementation, actually, from the OSCHR report. This is our big chance, so, you know, we need to go with it. And sure, I absolutely know this. I walk this walk in terms of both higher education and the NHS, is that we are challenged by increasing demands and cost pressures. But our future is to be as collaborative and as joined up as possible. Just next click, Emma. so that every tiny ripple can turn into a wave. Thank you very much. Back to you, Annette.
Thank you so much, Jane. That's brilliant. And it's so exciting, I think, to see the work that's even happening in the last couple of months, isn't it? And seeing where it's coming now.
Amazing. After all those years of waiting, the last 6 months, transformative. Yeah.
And I think you're such a fantastic advocate for us all driving that forward. So thank you so much for all your real hard work, Jane, within that. We've got a tiny bit of time, so there's one quick question in the chat.
Okay, yeah.
So just where can we find the careers map, Jane? Where's that available?
Oh, it's in the Catch website. I think the Catch was on my slides, the actual website, but if I couldn't quite see it as I was going through it, but I will put it on, and then when you all get it, oh, somebody's putting Catch in there. Thank you, Andrea Hilton. So it's in there, and actually Catch have been amazing. I'm pulling all the resources together for the first time, because when we started off as CARIN, you probably remember, Annette, we were sort of scrambling around for all sorts of things. The only thing not in there are things like the publications that people have done, but we keep a publication database too, as you know. But actually Catch have pulled everything together, so that's where the careers map is. Print it off and take it on board.
Brilliant. Thank you so much for that.
Thank you.
Okay then. Please, anybody, if you've got any other questions for Jane, put them in the Q&A, and then we'll come to them at the end. But we'll go on to our next speaker. So if that's okay, I think we've got Geeta next. So Geeta, have you got your own slides that you want to share?
I have, and I'm going to try and share them now. Yep. Can you see those okay? Yep. And you can hear me all right. Okay, lovely. So thanks everyone. So what I'm going to do is give a bit of scene setting on the EDI work that we're doing, just with a bit of background actually. So I'm a co-deputy chair with Hortensia Jimenez, who unfortunately can't be at the meeting, but for CARIN, but we also have a more general interest in this. So for example, I'm on the REDIC incubator, NIHR incubator, which is for race equity, but of course we're looking at EDI along many contexts for the work we're doing with CARIN. So but I'm a physiotherapist. I work at UCLH, and this is an area I've been interested in for some time. So I will bring some of that into this, and hopefully you'll find that helpful. And then we'll hopefully start to see how we're starting to weave it through some of the work at CARIN. So just to give a bit of context setting, Jane was already talked about the HESA data and actually have the problems with it. So actually what I'm going to present here is from HESA as well, but actually thinking about research leadership, then we're looking at professorial levels. So when we look at diversity and representation in clinical academia, these are some older data, but tracked over time, from 2013 to 2020, looking at who are the professors in terms of gender, well, male, female, and ethnicity. There's more recent data, which I pulled and put into a little graph the other day, where we can see that overall in 23-24, there's over 25,000 UK professors, only 8,150 are female. 2,000 just over identify as Asian, and 250 identify as Black. So those proportions don't necessarily chime with the percentage of people from different ethnic groups, for example, in the UK. And actually, there's also a concept that many of you may have heard of intersectionality, where you have intersecting experiences. So if we actually look at the number of Black women who are professors in the UK, there's only 70, which is actually 0.27% of overall numbers of professors. So this is just scene setting of why there is a focus on EDI, but obviously this is just looking at the race context. So if we're now looking at in terms of how does that affect us in terms of our success with certain metrics in academia, and in this particular example, it's in grants. So this was the NIHR diversity data. And so what we can see here in their data is that we can that certainly we see a larger number of female researchers applying at pre-doctoral level, but actually that really drops off for senior investigator programs. So again, it's that there seems to be this bottleneck going into seniority that the other slide indicated as well. That people from ethnic minority groups were likely to be less successful. And then actually, when we're looking at who receives funding here as well, there was actually only a tiny amount of data of people who declared a disability. So that's a concern as well. I know that NIHR have been working really hard at this, but at that time there was only quite a small proportion of people from ethnic minority groups, or certainly diverse groups, on the funding committees. But I know that there's been a big push for that, and actually that has improved greatly. And even the panel that I sit on, it really has been quite a transformation actually, which is great. And it'll be interesting to see how that works in terms of when this is re-looked at. So a lot of my interest in this area has been it's been sort of reflecting on my own journey, and I don't sort of want to be indulgent with this, but it's just to illustrate a point when we're thinking about the minority experience. And so when I talk about the minority experience, that's also for me as a physiotherapist, a small profession, trying to do research in a space that's traditionally occupied by medics. And some of the things that have come up and some of the challenges are things like the imposter syndrome, and actually a lack of role models for me as physios, particularly as I'm employed in the NHS. Other people's perceptions, and so where I've offered to do things, I've been asked to ask my PI's permission, even though I've been the PI on a certain grant, for example. There's a need to educate colleagues on the importance of my research area, which is quite a rare area, but in rehabilitation, for example. I mean, that you can also be a victim of your own successes, that your opinion is sought on everything, so you get very busy. But I have to now, I've worked my way up into a reasonably senior position, actually leverage the privilege of me being there to bring on other people is actually really important. And actually there's a real reflection of a similar experience of me as an ethnic minority woman. Similarly, imposter syndrome, a lack of role models. I was asked after bringing in an NIHR fellowship by a senior member of the university, saying, looked at my badge and said, "Do you work in admin?" So people's perceptions, and then again the intersectional experience, and also I just wanted to highlight the navigating of safely the safety of speaking up, because I know I'm people who know me well. I know a few people on the call know me quite well. I will speak out, but I know that I have been uninvited to certain spaces as a result of that, because sometimes speaking the truth can be uncomfortable for those listening. And I think when we're thinking about EDI, that's something, if we're trying to encourage voices, we have to make it safe. We have to sometimes be prepared to sit in the comfort of actually other people's realities, which might be different to our own. Again, I'm asked to lead a lot in EDI projects. I've watched others leapfrog over me, but I'm British born, I'm from a mixed heritage background, and I have a privilege that has allowed me to get where I am. So that means I have to mentor and support other people to come through. So leveraging privilege is sort of a message to really, really push out there. So some work that a group I've worked with have done in this space, we called ourselves the Disruptor, the global majority of disruptors we called ourselves. And this was some Health Education England work that was funded to actually explore the trajectory. We were looking specifically at physiotherapy, but as you'll see, a lot of this will apply across, and then some other work that others have done and are doing in other professions. So what we wanted to look at was the trajectory of people from physiotherapy, the profession, going into senior positions, so particularly at consultant level, and that also included some people who were clinical academics. And so this was sort of a participatory approach and using qualitative methods. And we identified social wrongs through that data. And we found it was multi-level. So there was the individual level, which you find a lot of initiatives focus on this. How do we give people the skills? How do we give people the knowledge to give them the confidence? But there was people's internalized oppression actually came through. But there's also, this is really where I think CARIN comes in, and work that's been done in institutions about understanding the system level. So actually, when we were talking to people, that career progression wasn't always visible to them, to consultant practice and clinical academia. So opportunities were not presented, and it wasn't necessarily visible to them, but it was to others. And then at systems level as well, the act of gatekeeping that can happen. So who are encouraged to go for fellowships are supported in that way, for example, in our space. But also simple things like not being part of the team, and actually they're not being a sense of belonging and exclusion behavior. And unfortunately, there were some really quite pointed examples of that. So as a group, we came up with this model. And I think, again, this is really important for us to reflect on in the work we do in clinical academia and trying to progress careers, is again, this is just showing that the multi-level, so those are self-internalized barriers, where there are relational barriers, particularly we're thinking about gatekeepers with managers and colleagues, where there are structural gatekeeping. So this is with some of the processes and the protocols. How can we make that a lot fairer and a level playing field? And then we've got these much bigger aspects as well, so organizational, institutional, and sociocultural. And actually going back the other way now, just a few little experiences that we came through where people, people were surprised when colleagues were promoted to senior positions. So that's that sense of belonging, where the support's not always there, that recognises the hard work. It's comparing what happens to people who are British, for example, and the respect that comes through that's not always afforded to other colleagues. I'll come back to this later, but this perception that you have to study harder than everybody else to be able to get through. And interesting, this came from somebody who was a clinical academic, who sort of says you're marginalized by who you are, and then the structures and the systems add another layer. And then they were talking about actually they'd paid a huge price financially by trying to struggle through both words, and that's a real concern. And then just sort of how do we bring the learning from the work that's been done before? Our colleague on CARIN, Linda, who's I know on the webinar as well. So she's actually been doing some work looking at MMAP research and dashboard data locally in the Northeast, and how you contrast that with WRES data, which is the race equity data from the NHS Trust, and noticed that there were some discrepancies in terms of who was in which positions, depending on where people were trained. So she's now found funding to actually do some more qualitative research. She's got a fellow doing this work to actually look at the experience of particularly internationally educated MMAPs engaging research, and they're at the early co-design phase. And actually what's really interesting, and when we've talked as a group, is that we also found in our disruptor work that actually it was the internationally educated colleagues who tended to have most challenges presented to them. So there was this real resonance across the work that we did and what Linda's been finding, and hopefully we'll delve into, and actually how do you then engage with those people to help design the solutions. And just going back to the disruptor work, some of you may or may not have heard of Eden Charles, and he does a lot of work for the NHS Leadership Academy, and he in his work talked about this bicultural competence model, where there is the in-group in certain institutions and organisations, but that can exclude others, and actually where people can draw strength from outside the workplace, and actually how we should be avoiding these deficit stories. So as in the deficit in the individual, going back to what I was saying earlier about actually the individual is only part of it. But there's a model I just wanted to point out to you that he talks about, and it's the PI model. So actually for us to progress, it's about performance and working hard. it's about your image, that personal brand and attitude, and it's about exposure. And actually, in the research that he's done, he actually found that exposure was a real part, a huge part of it. So if we go back to those comments earlier, about people not finding that there wasn't a visibility of opportunities and seeing how other people were exposed to opportunities, and actually performance is only 10%. But going back to, again, the comment about you have to work twice as hard, 10 times as hard as everybody else, it's something that I've always been told. I was told from childhood, you have to work 10 times as hard as everyone else. So actually, we could be absolutely thrashing ourselves to it, but it's only going to make 10% of the difference when actually this, which isn't always afforded if you're not in the in-group, is actually what gets people on. So just a bit of food for thought there when we're thinking about how we do support people and develop people through, and actually how we mentor people. So with that in mind, this is something I often will present to at some of our regional support events, how when we've got people who are emerging research leaders, encouraging them to increase their visibility as a result of that exposure piece, thinking about it at different levels, local, national, international, if that is accessible to them and within their profession, encouraging them to network to actually really leverage that and actually taking those collaboration opportunities. But also for them and for us to think about as well, when we're building our teams. And I think I've done this a lot, that self-awareness, that going back to how I leverage my privilege and my learning style. I think that's something that's important. We might be pretty senior of this webinar, but sometimes there's no harm in just taking a step back and having another think about how we do reflect on how we can support others. And certainly aiming for diversity in teams, we know that it fosters creativity, which will only help all of us, really. And then actually when we are supervising others, and this is something I've been really conscious of, this last point here, handing over my voice on different platforms, because for a while it's, I get approached a lot, and then I just don't want everybody to hear the world according to me. So actually I've been putting other people forward to talk in this space as well. And I think that's important for all of us to think about that too. So I think just to sum up, really, how do we ensure diversity? And I also do work in terms of actually looking at diversity of participation in research. And there was some real similarities, which is why I've put them side by side. Why is there a problem? Is it because individuals are not taking opportunity? Is it because the quality of applicants is poor? And then we think about our patients in research, for example. Is it because people are hard to reach? I don't really like that phase, or is it that people aren't engaging, and why? But actually supporting people, how we co-produce strategies like Linda's doing in her project, and how we engage people is really key to think about that at an individual level. But certainly, we should be looking at other policies and strategies as well, so that they're positive and they're purposive, to really give people that first step to then be able to flourish and then bring others with them. And actually really that we should be disrupting the systems rather than just focusing on the individual, which I think there's a tendency for that to have happened previously. So I'll stop there, and hopefully there might be a minute for a couple of questions if anybody's got them, and I'll stop sharing as well.
Thanks, Geeta. That's really interesting, and thanks so much for sharing that. The quotes, they really get you. I think that's not easy reading. Okay, anybody got any questions? I think you're let off the hook for now, Geeta, but what we'll do is obviously we'll leave it open, and then we'll bring it back in the end. Thank you so much for presenting. Thank you. Okay, then I'd like now to hand over to my colleagues Mary, Michelle, I think, and Fiona to look at the career framework, please. You're around.
Thank you. I'm just going to share my screen, and hopefully you can see that. Can people see that? Somebody's going to have to say yes or no, because now I've shared my screen, I can't see other people. So
Not yet, Michelle.
No, okay. When you have a practice session and it all works beautifully. Let's try again. Share. Does that work now? Can you see it now?
Yes, we can, Michelle. It's coming through.
Just put that onto slideshow. We've been asked to speak about some of the work that we're doing within the careers work package, and I'm speaking on behalf of my colleague Dr. Fiona Maxton, who is also on the call and will be able to field questions as well as myself. Just to give you a little bit of background, so the aim of this work package is to support the network in navigating the very complex career landscape. And I think Jane and Geeta have given a really good example of just where the challenges are in this space around the HESA data and how we try and work out where we are. And Geeta has given us a really good example of why this is so important in terms of, I loved the description around exposure and image in terms of visibility and understanding who we are and how we network and how we connect. So the main aims for the career work package for this coming year and over the last year were to develop a professor of nursing repository to try and describe the nature of embeddedness in health and social care providers and universities of clinical academics, to increase the visibility and access for early career researchers to find senior academic connections, and also to inform the metrics survey. Now, the reason that we're focusing purely on nursing is that our colleagues in our AHP colleagues and our midwifery colleagues already have resources, and if you're not familiar with these resources, I've QR coded both of them, which are fabulous resources around being able to find those senior research leaders and professors in your profession. You can see here the ones housed on CAPA, and you can search, you can filter by profession, by region, and you can see whether or not people are jointly employed by 2 employers here or have 1 employer. And similarly, you can see that they in the Professors of Midwifery directory, you can also see the areas of specialism. From a nursing point of view, we don't have a similar resource, and so that's why we're focusing on that. Some of the challenges and why we're focusing and thinking that this is an important part of the career framework. This is a hot off the press, recently published review around the challenges of nursing leadership in research and academia. That's a narrative review looking at all of the evidence over the last 20 years of the enablers, barriers and implications for policy and workforce development. And what that shows is things that we probably already know, but bring it into clear focus, is enablers of career progression are early exposure to research, structured programs, and we're better and more able to have that than we ever had before. And the work that OSCHR are doing, the work that Jane's doing within the implementation work, we're in such a stronger position than we've ever been. But areas where we're not doing so well are visible role models, and Geeta's talked very eloquently about how important that is, and also cross-sector partnerships that create protected time alongside mentoring to support people to develop. They're the enablers. The barriers are that we have few integrated pathways across the sector, and we've also got poor academic and clinical alignment. This is what the results of this review showed, and limited senior posts. There's a lack of mentorship, clear role definition, gendered expectations, and you can see that where our work influences or hopes to influence that. And research cultures are weak or poorly developed in many of the health and care settings. So the work that we're doing is, and this is another project, a guide for chief nurses, which is I am pointing towards for as a really good resource. But I want to particularly focus on our work package is focused on the 2 in the middle, which is embedding research practice in careers and workforce planning, which there's a real opportunity for us to get better there. And these are 2 key phrases of the challenges here, is that involvement in research can be hampered because staff don't know where to start and don't know who to reach out to for support and advice, which is why these directories, professorial directories, are so important. And that success in these competitions often depends on a demonstration of a record of accomplishment of partnership working with HEIs. So again, being able to support partnership working. Now, we have previously in nursing and midwifery professoriate had a directory, and the work that we've been doing in this area, I want to acknowledge that we have built on the work of the RCN in terms of their directory that was open between 2003 and 2015. And their directory showed that we had a growing number of professors of nursing. However, when you compare that to the number of medical professors, it's a small number. And what we're keen to see within our work stream is to see if that trajectory has plateaued, whether it's going up. Well, you'll be pleased to see that the work that we've done in 25 and 26 shows that there is a steady increase of professors of nursing, which we're really encouraged to see. We're collecting data and it's still open. I think we're about 90% there in terms of the whole reach of the UK. One of the areas that we're looking at, which is the geographical distribution of our professors of nursing. And you can see from this slide that there is a very clear geographical inequity around London and North West have a significant number of the professors, over 100 of the over 100, so nearly 50% of the professors of nursing are in London and North West in terms of England. And you can see that the devolved nations there have 23, Wales has 21, and Scotland has 26. If you want to be involved in this work and join in the data that we're collecting, please do contact us. We're continuing to add to that database in terms of trying to get the best possible representation of the professors of nursing that we have. The other part of the work that we're wanting to do is within our professoriate, look at the range and reach of clinical academia. And Jane has already spoken about the incredibly important developments in policy around the follow-up principles and clinical researchers in the United Kingdom. But in terms of our definitions, we need to acknowledge just how difficult it is to understand whether or not you're a clinical academic, or whether you identify and clearly create visibility as a clinical academic. In the follow-up principles, the definition of a clinical academic is any health or care professional who works in higher education institute in a teaching or research role, as well as working clinically in an NHS organisation or other care provider. So that's teaching or education. So that would include a lecturer practitioner. And it's really important that from a follow-up principles, it's very inclusive, and it talks about any joint working between HEIs and NHS providers. More specifically, in the OSCHR report, they're interested, as the title says, in clinical researchers, and clinical academic here is used to refer to people from regulated nursing, midwifery and AHP professions who have a defined role to undertake research with a joint appointment between the university and NHS organisation. And when you read these definitions, it's really easy to figure out and go, well, I'm not entirely sure which one I fit into there. I'm not sure if I am a clinical academic. I'm not sure if I've got a clinical research career, as Jane talked about in those in the diagram that she shared around clinical research careers. This is another framework from the NIHR, which is if you come from primary, hospital or community and residential, these are all of the different roles that people who have a research career could do. So, and the ones that I want to point out and talk about is clinical academic here is one small point, but advanced clinical practitioners will be doing research, clinician researchers are another group. And what I'm hoping to do here is if you're confused at this point, then you'd know what's going on, is that this is a confusing picture and it is very complex. And what we're hoping to do with the work that we're doing is develop a graphic to, this isn't perfect, but at this moment in time, we're not looking for, I don't think people are looking for perfection, but they are looking for something that's understandable about describing the clinical academic complexity that we have. So I'm going to have a go as this is where we're up to at the moment with the data that we've been collecting and the way that we're describing it. So In the circle in the middle is if you work in a university and employed by a university, you could potentially be contributing to health and care research, but have an inactive registration. So you may well have previously been registered, but you've let that lapse and you've got no clinical links, but you are doing research that is relevant to healthcare and you're a health services or health researcher, but you're not required to be registered for your role in teaching and research. Or you could have an active registration because it's mandated, certainly within nursing, it's a mandated part of you need to have a professional registration to be an adult nursing lecturer. But you may not have any clinical links at all. But there are two other groups of staff within universities. There are a group of staff who are full-time university academics, but do have active links. They may have active links in terms of they've got honorary clinical contracts. They may work on bank shifts to develop their skills or keep their skills up to date. They may have private practice. They may actually be PIs and chief investigators in trials and have honorary contracts because they are recruiting trials in NHS or care settings. So they have active registration, and there are academics that have active clinical links. Or you could have an active registration and you're clinically embedded. And this is the group of people that are considered to be clinical academics. But what I would argue to say is actually lots of people in the orange segment, and these segments are not, there's not an equal distribution, so we're still working out how we represent that, but you could argue that everybody in that bottom section is a clinical academic in some way, and what we're trying to do is develop the ways that academics are clinically contributing. But certainly clinically embedded academic is the term that we're using for people who have maintained their professional registration, are academics in university, but have clinical sessions and a job plan with an NHS or provider or organisation. If you flip this in terms of, well, if you're employed in a health or care or an NHS setting, the corollary of this, you could almost say that there's a mirror image, and the corollary of this is that you could be a health or care professional and have no academic links. That's not what we're hoping for. We're hoping that most people are in, if I can get the next, that most people who are health and care professionals, we aim to have active links. So the corollary of this is if you're an NHS employed person, that you could potentially have active academic links, honorary contracts, but we do have a number of clinicians who are academically active with a number of universities. They may be supervising PhD students, recruiting studies, and we've got a number of people in that section. We've got very few people, and that is the group of people that we're trying to encourage more, is health and care professionals who are academically embedded in research groups, or who are clinicians, but they're also clinician researchers and have hybrid roles, which I think is this section in the NIHR framework. And I'm hoping that graphic, as we build it, helps people explain the complexity of the difference between a clinically embedded academic and an academically embedded clinician, and that our ability to move people from active registration and active clinical links to full embeddedness. And this is a work in progress. We're really trying to explain and describe the complexity of clinical academia, and we hope that it helps the work going forward as we try to make sense of this workforce. Thank you. So stop sharing my screen there.
Thanks so much, Michelle. That's brilliant. I love your diagram. It's such a complex thing, and trying to explain to individuals, isn't it, who don't get it, don't know. It's just so complicated. So it's something simple.
So that's the project that we're trying to do. So we're mapping all of the professoriate, their areas of expertise, to try and communicate to those people who don't normally inhabit this world a simple way to provide to help people explain that complexity.
Thanks, Michelle. And just there was a comment came up in the chat about the profs in NHS organisations. You know, they might not be included in that list. And I remember going through the list, but we were going to include them on.
Yes,
so again,
yes. Irrespective. So this isn't about where you're employed, irrespective of whether. And also some of the feedback when I've been presenting the diagram is to make sure that the diagram encompasses all. So I first started off with if you're employed in an HAI, this is what it looks like, and if you're employed in the NHS or care organisation, this is what it looks like. And now people have asked me to combine the two, which is that attempt. Work in progress. We're still working on it, but that's where we're going with this.
Yes. All I'd say is if you've got a profile out there, you know, if you're a clinical academic or if you've got joint appointments, please put them on your profiles. Please give us an idea.
Please do. Absolutely.
We're having fun, weren't we, Michelle? When we're trying to find where people were, what they were doing, it wasn't easy to find, and we were trying to hunt.
Absolutely. And we're really only focusing on what people identify themselves to be. So if you think that you are one of those things that I've put on that diagram and it's not on your web profiles, please put it on.
Yeah. Brilliant. Thanks again, Michelle. Right. Lovely. Thank you so much. And finally, let's hand over to Mary. Great to see you, Mary. Hope you're okay. Mary, you can't hear you for some reason. Or I can't. Is it just me?
If you just check your microphone source next to the audio button on the screen on the left, bottom left. Try speaking now. No. A little up arrow. There might be other options of different microphones.
Can you hear me now if I take my headphones off?
Brilliant. Thanks, Mary.
You can. The problem is everybody in my office can now hear me as well, but hopefully they'll be okay with that. You can hear me okay?
Yes, can hear you perfectly well. Thanks, Mary.
Okay, because I can't hear you terribly well. Apologies for that. For some reason, Zoom seems to be quite challenging today, but I'm going to share my screen and I am here on behalf, hopefully you can see that. Can you see my window? Can somebody tell me, because I can't see you. Great. I'm here on behalf of Professor Lynn Kalman and the CARIN Metrics and Impact subgroup. You have heard a lot today about the kind of context of where we are in terms of clinical academic careers. And the survey has been a very important part of that over the last few years. But I haven't actually brought any slides to present the results of the CARIN survey from previous years, because I think you've heard me talk about that a number of times, including at last year's webinar. So the last time we did the CARIN survey was actually in 2024, looking back at the calendar year of 2023. And this is now a biennial survey, so we are just about to launch it very soon. So I'm really going to just give you a kind of view of where we are, how we're thinking about moving forward with the survey, and what the current state of play is. So, oh, my slides aren't moving.
Mary, it looks like you're on presenter view as well. Can you change it?
Oh, I can't. I don't know why this is not working.
If you click
sorry, I really ought to be a very experienced presenter.
If you click display settings on the top, press that.
That better? Thank you. Sorry about this. You've heard already today about the OSCHR report, which I think is a very, very important step in the right direction for all of us. And you've heard several speakers today sort of highlighting the issue that we're all very, very familiar with, which is that from a nursing, midwifery and allied health professional point of view, we have a relatively small number of clinical academics. And there are long-standing barriers towards these careers for us. And you'll also have heard from Jane that one of the key actions of the OSCHR report is to generate robust context-specific data on the number and distribution of clinical academics. And, you know, Michelle has kind of given you a really good insight into how complex this is. And given the complexity that Michelle's just described, capturing that robust context-specific data is extremely challenging. And Jane has already indicated that, you know, even within academic institutions, we actually have quite poor data capture on our nurses and midwives and allied health professionals who are working in higher education institutions. But obviously the CARIN survey fits very much into this key action and in fact was referenced several times in this report. But the report did point out that, you know, this was kind of snapshot data and that we didn't really have anything better. So the way that the CARIN survey is set up is, as I say, is a biennial survey, which we're going to be doing again in the next coming months. And we have made a decision to report on the previous financial NHS year now rather than the calendar year. And really the survey is going to help us with mapping what our clinical academic workforce is and our research environment across organisations. So it's always been a survey of organisations and not a survey of individuals. And many of you who are HPs will know that CAPA recently have published a survey of individuals. And of course, that would probably be the ideal because we would probably have better data, but it's actually very, very difficult to know that you're reaching all those individuals in every corner of all our organisations. So this survey has been designed as a mechanism of asking research capacity building leads across our health and care organisations to complete on behalf of their organisation. And just to give you a sense of how many responses we've had over recent years, this survey started in 2017, and you can see that in 2023, we've more than doubled the number of organisations that sent in a submission. However, 42 organisations in the whole of the UK is not very many health and care organisations. Jane mentioned the number of members we have in CARIN. We think we have roughly 69 different organisations, health and care organisations who are part of CARIN. So this year, I don't know what our response rate will be, but it would be fantastic if we had 69 entries. And it would be fantastic if anybody is on this call and is not currently a member of CARIN or is currently not an organisational member of CARIN, if you could join so that we can include you in our survey this year, because we'd have a much, much better picture then of what's going on across the UK. Those of you who've heard me present this before will know that last year was the first time we actually had entries from all our 4 nations, but we have got much fewer entries from Scotland, Northern Ireland and Wales than we have from England. So the plan at the moment for the next survey is that we will be sending it out, as I say, in the next sort of month or so. We've been through the survey with a bit of a fine-tooth comb, and we've made a number of revisions complete with input from the subgroup, and I'm very grateful to those members of the subgroup who've given some really useful insights into both the challenges of completing the survey, but also the data that we really need as a country and as a whole. We decided that we've kind of done this on a little bit of a, well, we've always done it on a shoestring, but we've also done it in kind of quite a casual way for a group of researchers. So we have now written a protocol for the survey. We are still going to use MS Forms. We did dabble with thinking about using Qualtrics, but actually the data sharing, because Qualtrics is held by universities rather than by NHS trusts on the whole, the data sharing was just looking too complicated. So we are going to continue to use MS Forms. We are putting it through service evaluation approval at Guy's and St Thomas's at the moment where I work, in order that we do at least have some governance around the survey, which has really just been an internal thing for us before within CARIN. As I said, I've told you the dates of when we're planning to disseminate the survey, with a couple of months or 6 weeks for people to fill it in. So this is kind of a heads up for you to be thinking about how do you get hold of the data that you would be putting into the survey when it comes to you. We're going to be doing the data analysis at Guy's and St Thomas's and at the University of Southampton, where Lynn is based, and we will be sharing an anonymised database with the Council of Deans. So there are 3 sections to the survey, and the first is about the research environment. And obviously, you know, this has been designed to really align with the Research Matters toolkit that Michelle just shared, you know, and with all the other work that's going on. So research environment is really about culture, strategic support, support in equity, etc. And we're asking people about the size and the nature of their organisations. So we've added some drop-down boxes for different types of organisation because, for example, we've now got hospice members in CARIN as well as NHS hospitals, etc. We ask about the number of employees in terms of NMAPs, so that we can understand how much our capacity for leadership and support for research really matches the number of healthcare professionals we have in our groups. We ask about strategic support for research, so that's things like, is there any mention of NMAPs within the R&D strategy, and is research part of the nursing, midwifery and allied healthcare professional strategy, for example. We ask about substantive leadership roles, and that's actually really important in terms of understanding equity across the patch. We ask about different types of links with HEIs, joint contracts and things like that. And we ask about mentorship, training and support for research. So those are the kinds of things within the research environment. We then ask about the clinical academic workforce. So this is quite complex because, of course, people are in all sorts of different posts, but we ask about any clinical academics, apart from research capacity and capability leads, who are not currently undertaking fellowships, and if there are any, and what kinds of contracts they're on. We ask about the number of staff with doctoral qualifications and the number of people who are doctorally qualified who are actually active in research, which is, I know, a very hard thing for some organisations to answer, but it starts to give us some sense of, you know, in a way, the corollary of what Michelle was presenting, those people who are in the NHS or in hospice care or whatever, who aren't actually able to use their doctoral qualifications. We ask about support for postdoc, and we've added a section this year on number of PIs and associate PIs too. We ask about regional and local schemes that are open to our professions, and we ask about the number of people who are on different types of fellowships across that pathway that Jane showed you. The final section is on outputs and impact, and this is a tricky one because an awful lot of organisations don't actually have this data. So we're asking about, do you have data at all on any of these things? And if you do, then can you tell us about it? And we also importantly include achievements and challenges. And this year we've also added some a kind of inclusion related question that is about, are you doing anything specific to address the challenges of, you know, particularly underserved groups, you know, any kind of ring-fenced funding, for example, for people from the global majority, etc. This is my last slide. So our plans and our aspirations are really to try and drive more accurate and robust data capture across the UK. We know that people have told us that the CARIN survey has helped them to think about their own data capture in their own organisations. So even if it does that, it is helping us to move towards the goal that we need to be at. It very much does help us to benchmark. And again, people have said to us before that it's been very helpful in them being able to have conversations with their own organisations about where they're at compared with other organisations that have more strategic support, for example. And this year we will be asking about our RDN regions, particularly in England, so that we also know what regional variation there is. We will, of course, be sharing the data with the OSCHR implementation steering group, which will help to form part of planning. And we hope throughout doing this work that we'll be able to influence funders' policy and practice. So that's where we are. Apologies for the technical issues at the beginning. I'm just going to end the slideshow and I'm happy to take any questions from the floor.
Brilliant. Thanks, Mary. I can't see any questions coming through. I think you've been.
I'm just looking at whether there's anything in the chat. I think there's mostly to do with Michelle's presentation.
Okay.
But yeah, so I mean, we have presented the results of the CARIN survey from last time many times, which is why I chose not to do that today. But I hope that gives you a kind of sense of where we're going and what to expect, really. And as I say, we really welcome new organisations joining so that we can have better data.
Yeah, it looks like Alison's going to be joining, so that's at least one more, Mary. But it's good to give everybody a heads up, isn't it? So we can start putting it in diaries and planning that work going ahead, because it will soon come out. You know, March is just next month, and it's not long to try and gather that data. So brilliant, thanks for sharing that.
There's just a question about what professions the survey covers. So is it solely NMAP?
Yes, sorry. I mean, I know I talked mostly about nursing, midwifery and allied health professions. No, it does include pharmacy technicians. It includes healthcare scientists, and it includes psychologists. The difficulty that we found is that a lot of organisational leads have had more trouble finding the data for those professions than they have for the NMAPs with 1P kind of thing. But we really do want to gather that data if we can, and obviously we want to try and represent those professions within CARIN as much as we possibly can as well. It always has covered those professions, by the way, since 2017, but it's just we don't have such good data, I have to say. People are surer about the nursing, midwifery and allied health data than they are about the other professional groups.
Brilliant, thanks, Mary. For some reason, I can't see anything else that's in the chat or the comments.
There is another question in the Q&A about sharing examples of mechanisms for data collection, with some institutions or organisations don't currently have those mechanisms in place, and if there's any examples that could be shared of how people collect the data.
Yeah, I mean, that's a very interesting question. I mean, probably the person who has, I think, the most sophisticated database is Linda Tinkler, who I'm sure is on the call. And Linda's done some fantastic work in Newcastle with Power BI and has developed a database. And we have been trying to generate some interest in thinking about how that might be rolled out. We have done some work, and we're currently doing some work here at Guy's and St Thomas's to try and sharpen and improve our own MS form survey that we do every year. And I mean, maybe this is something we should think about, how we, you know, perhaps we need to share a template of that. I mean, because, you know, it does take work to sort these things out. And actually, we've based our survey very much on what the CARIN survey requires, but plus some kind of additional information for us that is very trust specific. So, you know, if people have got access to MS forms, I mean, I think in the interest of you know, the whole of our membership, perhaps that is something we should consider making more public. Michelle's got her hand up.
So in Liverpool, we've developed a red cap repository. So and we're certainly sharing that with other Liverpool hospitals to try and collect that data on an ongoing basis. So rather than having one survey a year, we continually collect that data and put it into a red cap repository. But I think maybe that sharing those types of examples, because you're absolutely right, Mary, those take a long time to build. Yeah. And if there's a way of us being able to make those shareable.
Yeah, can definitely take that to the group and see how we think would be the best mechanism for doing that. Jane?
And yeah, I absolutely agree. I think that's a really good suggestion from today. So thank you very much. And we could take that back to the CARIN leadership, but also the CARIN membership. We've got an in-person meeting coming in March, so perhaps we can talk about that and then how we share that resource. CARIN has been excellent at sharing resources via the Council of Deans of Health. So yeah, let's do that. I think that's really good. And Michelle's nodding, and yeah, we're all in agreement. So thank you very much.
That's a great suggestion. Thank you.
Brilliant. Yeah, I mean, I must admit, it's really great in Newcastle to have that database, and Linda's done so much fantastic work with that, but also secured the funding support to actually build that and develop that. And it's making such a difference within the organisation to be able to share that data across multiple different levels. So I think it's really important that we start to build that and have these resources within the organisation, because that's the only way we're going to demonstrate, isn't it, the growth, the capacity.
Yeah, I mean, I think, there's nothing like being able to show your own data and to sort of illustrate that it's not quite perhaps as good as somebody else's. And that's a kind of big lever for people, I think.
Thanks. Robin, can you see any more questions in there? The bot?
I don't think so. I think everyone seems to be saying thank you, and it sounds like a good.
Fantastic. So just to say thank you again to Jane, to Mary, to Michelle and to Geeta for presenting today. It's been really great to share the work that we've been doing within CARIN, not just for the last 12 months, but since CARIN's been ongoing. And I think you hopefully appreciate the amazing work that's gone on, but also the strides that's happening now, and really exciting times coming ahead. So it's great to hear that from you, Jane, and looking forward to seeing there's new opportunities coming forward that we'll all take part in, and collecting that data support. So just thank you again to Council of Deans for hosting the webinar today. Thank you all for participating and for your comments and questions. The slides will be shared, and please get in touch with Jane or with Emma or Council of Deans if you want to be a member. As you see, it's free. Myself and Polly will do a newsletter as well with regular updates about what we've been up to and the activities going on within CARIN Group too. So thank you. Take care, everyone. Safe journeys home, and look forward to seeing you again next year.